citizens, how to access open data. And Laurent and Alexandre, if you'd like to come up. Antoine Flahault. Hello, Laurent. Antoine Flahault. Signa Gruson-Daniel. Thomas London. And the debate will be moderated by Denis Silbert. Before we start, we have a surprise if you'd just like to watch the film. So from the world of finance to that of transport, from the field of security to that of marketing, all major sectors need big data. All of them except the healthcare sector. In this area in France, the computer processing of gigantic volumes of data seems to be frightening rather than make us happy. And yet there is treasure there. It's jealously guarded in the virtual safes of the DHSS in France and the technical agency in charge of information about hospitalization. Billions of data have been built up over the years. Their value is inestimable, and it might enlighten us about what's happening in the healthcare sector, in hospitals, in GP practices. Maybe we would be able to identify problems and inequalities in our system. If we had access to this data, maybe we would be able to know that certain medications are not useful, or there are certain populations that are more inclined to become obese. Perhaps we would be able to spend money better. McKinsey recently evaluated at $450 billion the sums that might be saved in the American healthcare system. But beyond the problem of efficiency, it's also a question of transparency in relation to citizens. If we could go into the archives, in fact, the agency in charge of medication in Europe is going into the archives and having lots of access to different clinical tests. When are we going to get this kind of democratization in France? But for the treasure chest not to become into a Pandora's box, we need to think about confidentiality and then see where we go, because the potential is absolutely mind-blowing.
Bonjour à tous, Denis Silbert, impliqué dans l'e-santé depuis longtemps et organisant un congrès qui a pour vocation de faire le panorama sur ce sujet, donc Doctors 2.0 and You. Nous avons vu émerger plutôt récemment l'importance du big data et du open data. Et je voulais juste, avant de donner la parole à chacun, essayer de reclarifier, parce que nous allons sûrement parler des deux termes. Donc,
to be talking about both terms. And in fact, big data, open data, we're interested in it as soon as it's big. So this is the relationship between the two. Big data, we're talking about terabytes, so it's 1,000, it's the fourth position. And for several years now, we've been saying that we've got the 18th degree of data created every day. So that's huge. Now, curiously, and in relationship to the title of the conference, in 1989, in the Declaration of Human Rights, we can say that there was a reference to the beginnings of open data. In Article 15, it says that we can ask people to report on what they are doing, especially public agents. Now, the importance for us is that the real opening of public data allows us to go so far, because up until now, research was organized around what we can anticipate. You create a protocol for something that you know exists, and with the opening of master data, we can set up relationships that we didn't suspect in the past. I'm going to start by asking Antoine Flahault, who is a specialist in healthcare. He is known across the world. He works for the Geneva and Paris universities. I'm going to ask him how he sees this question of open data in the healthcare sector. Thank you, Denise. I think that there are several aspects here. There are aspects linked to research itself. It's possible that this movement, this big data movement, may have a considerable impact on research. You know, epidemiology. There is clinical epidemiology, but it's fairly conventional research where we set up hypotheses, and based on these hypotheses, protocols are set up, data is collected, analyzed, and then conclusions are drawn. Now, big data really is part of the movement of astronomers in the 18th century. It's more like this. By observing the universe, they can find out how the stars work. In other words, there's a kind of upheaval, if you like, a complete upheaval of the system. So as of big data, as of the big data, massive data we have, and as you said, we've built up more data over the past few years than we built up until 2003. So we have an enormous amount of data surrounding us. And as it was underlined in the film, these data are not very well used in the healthcare system. They're used a lot by marketing and finance. They're not very well used in the healthcare system. In the healthcare system, there are promising applications, however. For example, big data, we're talking about several sectors. The internet sector is a highly promising sector. Today, we could probably say that there isn't one organization, one healthcare or monitoring center that isn't looking at Google in order to look at flu and how the flu is evolving. When you go onto Google, you enter words, paracetamol, fever, flu, and these words, if you look at them, these are words that are tracked, and they track peaks in epidemics. So if you go, usually you go on the internet before you go to the pharmacy or before you go and see your doctor, because there are medications that can be taken without any prescriptions. So medications can also be trackers. So there's a second database, the database of medications, which is huge. Again, it's all about big data, multiple sources, all going very quickly. That the flow never stops, in fact. So these trackers can allow us to monitor what is happening in terms of epidemics. And I think this is true in many, many areas. There are other examples. It's not just internet. Satellites that are above us in the sky build up an awful lot of data. Today, papers have been published that underline that we can forecast lots of different things in far corners of Africa, for example, where there is not much monitoring. We can look at Rift disease, which is a hemorrhaging disease almost as serious as that of Ebola. So these satellites measured pollution as well. And we can really control pollution peaks in our cities with satellites. So these satellites, they are there all the time. They don't always open up their data to researchers, but they do give rise to some great papers with some promising ideas. Now, I haven't talked about hospitals and health insurance. We'll be talking about that, but I did talk about healthcare monitoring. We've talked about marketing, education, and there are many applications that are really based on papers, research papers. So we need to move from the paper base to the routine base in France, but also a little bit everywhere, really. In France, we're just beginning. So this is the transition with Célia Agrousson, who's going to be explaining to us what a PhD hacker is and talk to us about her applications.
Good morning. Thank you, Denise, and thank you to Sham for having welcomed me and giving the opportunity to talk at this round table. We're an association of researchers around open science, which means being on the watch and giving advice to students on the way that they should carry out their research today, with access to free publications, scientific articles certainly, but also open data, and research in new areas, which raises issues for the researchers, and including data in health research, things that are quite complicated, and researchers often have difficulty in understanding, knowing what to share, how to share it. And in terms of open data in research, it's very important to have the right concepts in terms of educating the researchers, making the data anonymous, is something very important that a lot of young researchers now do. And on legal level, for the moment, things may be a little hazy still. We're in the area of open data, but there are no answers, and there are certainly licenses as well attached to these data. You can give information to the researchers, but you've got to be familiar with the new laws that are now being set up. So it's something, it means permanently switching between what happens and the legal aspects of open data, and making the searchers and citizens aware of all this, because open data is theoretically public data. It's medical and administrative. It concerns your health. And any citizen should be able to have access to it with Article 15 that you quoted. But there are a lot of concerns in this area, because very often people don't know what data is, don't know how to use it, don't know how to see this with a critical eye, and find what is hidden behind it. I think that in terms of education, this is where our association and others such as the Open Knowledge Foundation can give you the keys and help people to have a critical attitude to these data. So one might think that this generation of students is going to be more demanding in terms of access because they've been trained for that. Well, I think that they want to share, and there are issues related to sharing, and they do have a critical attitude to these new data being created. So we have two prospects here. We have the public health aspect and young searchers attitude, and we're fortunate enough to have London from McKinsey here with us today. Well, recently we mapped out the data that exist in the area of health in France and how it's used worldwide. And we started to approach the issues of big data and open data and how it's applied to research. That's the first thing you think about is how can we use the wealth of information that you have in this huge, massive data and give the scientific community and industry better access to it to stimulate innovation. There are lots of potential benefits, and there are at least 3 types that are used from one country to another. The first of these 3 is basically helping to make decisions for patients and health workers. This is information that can be found on sites such as Doctissimo and so on. But in some countries, in Germany and in Great Britain, for example, people have information to their health pathway, which enables them to select the right doctor, for example, and that's also accessible to the public. That's the second type of benefit, and we also see more sophisticated tools such as locating iatrogenic risks on a drug through the code bar on the box, and all sorts of other information relative to the patients. There's also information concerning improving the performance of the healthcare providers. And there are several countries in which now you can compare the hospitals, the doctors, the GP on the basis of a list of objective criteria and see how they manage their patients. In the US, for example, you get the hospitalization rates, the mortality rates for the hospitals, and how people are managed. This enables you to find the right healthcare practitioner, and also it enables you to put the pressure on the practitioners so that they improve. There are also patient associations This reinforces the democracy of health. Giving more information to the patients and our citizens, they'll be able to have more clout in terms of the main orientations of their health system. And also, they will be able to make an assessment. They'll be able to assess health policy and so on. So there's quite a lot of benefit in this. And this is what open data can offer in terms of its benefit in many countries now, even if it's at the beginning. Well, what's interesting with that group is that we've seen these three aspects, and we're going to go on to Alexandre's city. He is president of DNA Vision, and he's going to tell us more about big open data. The issue of big open data is a dual issue. The health system is going to be fundamentally restructured by big data because the data is really increasing very fast. We have an explosion of new data with 10 million new data. We've got multiple sensors that capture data everywhere. You've seen the agreement between Google and Novartis with the new devices to constantly measure glycemia. So we're going to have huge volumes of data that can't be dealt with by a human brain. No human brain, no normal human brain can deal with a DNA sequence manually. It takes about 50 hours to analyze it with an expert system. So this big data is going to lead us to expert systems and algorithms. And we'll observe a migration of the value. A medical procedure will be essential, but economically speaking, it won't be worth much. And medical power is going to migrate to the people who own these algorithms too. Behind these expert systems that are becoming increasingly powerful, we'll have millions of billions of information coming in for each patient. Remember Sergey Brin, who explained that they were going to make machines that are going to reason and think better than any human being can possibly do. And the director of development explained that very soon artificial intelligence will be more powerful than the 8 billion human brains. So no human brain is going to be able to resist these machines in the future. This explosion of the volume of data is going to have very high structural power on society. It's a sort of economic black hole. The two impacts will be, first and foremost, that of course data is going to be managed by people who are professionals in data, and the data that we have is not going to be used. We could do extraordinary things and have databases for social security and so on, but our data are going to be left aside because GAFA, Google, Apple, Facebook, and Amazon, who are investing hugely in health algorithms, will be developing giant cohorts. They have cohorts of 1 million people in the US, and they're going to make algorithms that are going to supersede us, and we're going to cry like the people who sold CDs and books and so on. It's going to be... if we don't understand the evolution of big data, we're going to lose all the power we have. And that's the second impact. Big data is going to lead to a redistribution of medical power. Medical power is going to migrate from the doctor to the person who owns the algorithm. Either the algorithms will belong to the public authorities and the doctors, like Antoine Fleau, who's done some wonderful things in this area, or the algorithms will be owned by GAFA. Google has invested a lot of money in algorithms, more than all the European health systems put together. And we are starting to see the impact of the entrance of Google into the health system. Through its Fly-by-Roon subsidiary, has hundreds of thousands of files in cancerology, is invested in diabetics and foundation medicine and so on and so forth. Today, it's absolutely crucial that we should understand that the value is no longer a medical procedure, and data mining and big data and data management are more important than nephrectomy or putting a stethoscope on somebody's chest. Whatever we think about that as a doctor, and it's very shocking for them to hear that, you've got to understand that if we don't take care, the doctors are going to be our nurses in 2030. They'll just be reduced to that. And what's happened for the booksellers and disc sellers should invite us to be cautious, because if that may very well be the equivalent to what happened in the digital economy over the last few years. We invest nothing in cohorts nor in big data. And we're now sequencing millions of people by crossing the data from all these people with their electronic medical files. The goal is to create algorithms, and in the future, we're going to buy these algorithms. And we're not investing, and to have an international health algorithm, we're going to have to invest millions of dollars. It's going to cost as much as doing the engine for Amazon. It's very important because the public authorities should understand this transfer of values, and it's absolutely urgent to do something, because we must remain sovereign. And for the doctors, of course, there's a big challenge too. As a corporation, are we going to lose our power in medicine and hand over to the people who own the algorithms, or are we going to be the nurses in 2030, or do we want to be independent? That's the issue that we have to deal with today, on the decisions that we take in controlling data and the fusion between big data, open data, and a health policy that includes those challenges for once, because they are international, industrial, and professional challenges. Now, how can a country rivalize with what is being prepared by the monsters of our digital economy? Antoine. Well, in point of fact, I'm very, very sensitive to quite a few things that Laurent has just said. What Laurent said calls for an immediate comment, I think. Because doctors, or at least the world of health professionals alone, can't win this battle. What you see at Paris Descartes and the University of Geneva is the first emergency for us is to build bridges. We've got to cooperate closely with the schools of engineering. Paris Descartes is working with Centrale Supélec, and they're merging too, to try and move forward research in big data in health, because that is based on algorithm. It's something that is extremely high-tech, which requires top levels of mathematics and information science, and of course very competent doctors aren't engineers. However, there are a lot of engineers today who are attracted to the health sector because it's a sector that makes sense to them, because it's a sector that may be more interesting for them to develop algorithms, not just to do pop-ups on Google because you're going on a trip or buying a book, but doing something that really does deal with real issues, health issues. And one might imagine, although this isn't going to be attractive just for reasons of money, to be an engineer at École Centrale at Lausanne or Supélec in Paris and be interested in these issues, because in fact it is crucial. And it's on the European level, not just on our country's level. It's on European level that we need to do something. People are paying attention today, and in the area of teaching, because all areas are really affected by open data today. It's absolutely crucial that the universities should organize themselves as well. But we mustn't forget the administrations and the politicians. They mustn't be too far away from this or adverse to it. And what we're doing today in terms of closing up our data and restricting access to just organizations of research, because otherwise it might be improperly used and there's a risk, is anachronical. And I think we're going to be completely drowned by this wave that Laurent mentioned. It's going to submerge all of the sector, so to speak. And if the public authorities don't do something, the challenge can be measured, because today France is probably the only country in the world that really has a database of 60 million people. Well, I was going to ask Thomas how we can start. What do you advise us to do? Because the issue is that SHAM has existed for several years now, and our idea is to shake things up and try and change things to the extent that's possible. And people are saying, well, everybody gets more or less good health care. I go back home and I'm not going to fight against the administration. Yesterday in the train when I was coming here, everybody was looking at the latest version of the text for our new health law concerning non-access to data, which is going to stop our talent from emerging, because you can't start by just teething on the genome. Well, I think that one of the strengths of France is actually the fact that the data we do have. We do have the data. If you have take a look at a huge system like the US system, we have a database which is not fragmented, whereas the American system is, and anything you get is always partial. The fact that we pool our data on tumors, for example, between the different anti-cancer centers is a strength. We've got something that really gives us a depth and breadth of data, which is good. But I think that before we start, there is a hurdle to overcome. We have lots of different things that are all aggregated together. We took a look at the access to individual data, and in point of fact, these data are never really available as open data. And the debate that says, well, we've got to open up our system tends, therefore, to be crystallized, because for a community, scientific community, we've got to make the access more fluid. So we're not yet in open data, but for a targeted population, we're going to have to make the access to open data more fluid. And to back that up, we are going to draw benefit from all the brains we have available in France, putting different competencies together, mathematics and engineering and so on. Okay, so I'd like to ask Celia a question. This new generation should start where? Where do you think they should start? Somebody is 14 or 15 in the US, just at the beginning of high school, has succeeded in identifying a way of identifying circulating proteins that mark the beginnings of cancer. Do you think we'll have a young French genius who's going to be able to do something comparable? Well, I don't think we need 20.2 when you graduate to do something interesting. But I think the main problem is getting access to scientific publications. This young man said that he wanted to launch into this type of research when he was very young, and his main difficulty was that to get access to the scientific literature, it often costs $30 an article. It's really quite costly. So that's something, that's the first stage that we need to think about. We've got to look at open access and how you can have access to scientific literature and all the information it contains. Today, if we give them access to all this data, interdisciplinarity and cooperation will improve. The US is ahead of us in this area. An example of this is the ISB Institute. They work on very complex issues in biology, and they've got a lot of data, and they open it up so that people can find what they need and move their research forward. And I think we need to be able to share this data, to be able to progress together, putting together different competencies in engineering, in neurobiology, and so on. And it's the only way we really are going to move forward. And I think that's something that is closely linked to open data in research. You've got to be able to share data to be more effective in your research.
Laurent, you told us, you set a scene that was quite definitive. You said this was absolutely inevitable for France. What do you propose to do, and what do you think is feasible for tomorrow? If you were in charge of this project to have France catch up for lost time, what would be some feasible things that you would implement? I didn't prepare this question, so we'll see what Laurent might answer. Well, I would change human beings. Individually, or there are a certain number of human beings who are blocking the modernization of the healthcare system. We have to stop all this hollow rhetoric. We're not going to be able to modernize the healthcare system and integrate big data if we have these conservatives, and we have these really absolute Luddites, and they're blocking the healthcare system. And you all know who they are. I think you do know who they are, these Luddites. There's a real human blockage. We cannot imagine that we're going to modernize a paradigm with technophobes. You cannot. It's not true. So there is a human problem that we need to solve. Then there's a change in paradigm, a real paradigm shift. We see that we were in a Malthusian logic with respect to this data. The texts that want to lock up the data are completely anachronous, and they're going to prevent the emergence of giants, big data giants, and open data and expert systems. Data, that's not the most important problem. Data is secondary. Data is what is going to feed the algorithm. The essential is focused on the algorithm. To create a European or French giant of healthcare algorithms, we're way behind. Do not mistake yourselves. To do iTunes of healthcare, it will take between $3 and $20 billion on the table. It's not locally near Poitiers that they're going to do that. And the French drama is that we're going to find ourselves in a situation where each IRS will create an expert system of their own. Claude Evin, working for the IRS around Paris, could do something. But I think in Corsica, they might have a hard time competing with Google. So there's a real paradigm shift. We're going to have to invest a huge amount of money. The French state has no money. And given the state of our budget, it's not the public authorities who are going to write a check for $5 billion. We need private actors. Either we allow the emergence in Europe of data platforms, or we will import these algorithms from elsewhere. And today, everything is done to prevent the emergence of players who have a good control of this data and these algorithms. And the public authorities here are committing suicide. Suicide for the healthcare system, for the insurance system in the future, for all the healthcare actors. Suicide for the doctors, because the French doctors won't participate in this algorithmic adventure. They will be left behind with respect to their American colleagues. We need people who are sensitive to data, such as Jean Carvastouet. They need to be managing the affairs much more than the technophobes that we have today managing our healthcare system. So what can we do? Well, there's no easy answer. We can't have these platforms like Amazon, Google, this type of platform emerging in France in 5 minutes. We're going to have to limit the regulatory barriers when they exist. Well, we need to preserve the privacy of patients, of course. We need to allow these startups to have access to data to bring up sectorial algorithms, even if the large manufacturers of algorithms haven't started yet. Now, let me come back to this power of IT. We're talking about big data. We need to keep in mind that the power of these servers is going to multiply, and it's going to be multiplied by 1 million in the future. We need to understand the fact that no human brain in 2025 or 2030 will be able to fight these expert systems for medical diagnosis. Doctors must abandon the idea that they will be making their diagnoses in 2030. It will be the expert systems that will be doing these diagnoses. So it's really urgent for doctors. It's urgent for all of us, and there are many of us in the room who are doctors, medical doctors. There's a real urgency to determine what we're going to do within this type of healthcare system. Are we going to be the new nurses, indeed, or are we going to find other niche, other areas to participate in epidemiological studies or determine intelligent healthcare policies? There are many things that we can do to reconvert doctors, but we need to keep in mind that we are not going to be the ones carrying out the diagnoses. We will be just signing a prescription that we won't have designed ourselves. Recently, Watson and genomics are an important aspect here, because Watson doesn't have any shares at IBM, but there was a question about the mutation of P53 recently, and Watson solved the question in a few seconds. A human being, it would have taken 38 years, day and night, to just read the literature. What a human would have taken 38 years to do, Watson did it in 1/100th of a second, and he found the solution on the solution of this protein, P53. So this extension of the field of artificial intelligence in a world where tomorrow our IT servers will be millions of times stronger, it's inevitable, and it should encourage us to organize the transition right now. In this transition, one of the roles of doctors will be to be actors in big data, open data, and in this new public health policy carried out by data. But it's urgent. The reconversion of the healthcare system is urgent. There are other sectors where reconversion is urgent. When you see the predictions of Guy Valencien, who thinks that 5 years from now, we will have robots, completely autonomous robots, who will replace surgeons. It's also urgent to determine what we're going to be doing with surgeons in 2025, but that's another issue. So today there's an industrial urgency and societal urgency, but also corporational urgency. What are we going to do with the medical doctors? This corporation must organize themselves in a clear-headed way today. We shouldn't end up like people who used to be selling film, like Kodak, 20 years ago. This problem is an economic problem. It's a problem of reconversion. We have to really be careful today and beware. Otherwise, the platforms will eliminate any need for us, and we will have a social crisis with a medical body that we haven't trained for the world of big data, and the explosion of these IT capacities will be a reality every day. I hear the discomfort from the audience here. I would like to also recall that there was already an urgency. There are 6,000 diseases identified, and there is fantastic. The people who don't have the 40 or 50 most frequent diseases are not privileged, because there's a resistance to use these diagnosis support systems that exist and have already been performing well for the past 20, 25 years. Let me ask Thomas and Antoine about this issue between public and private. Schematically, we could say that you're working more with companies, but also with the public sector, and Antoine perhaps more with the public sector. When we talk about open data, we always refer to the possibility for authorities to open up the door. But do you think the solution wouldn't also lie within the private sector? The technology to really make things move faster, do you think it lies in the private or the public sector? Well, if we follow the reasoning that we've just heard and the logic, which is to say we're facing a revolution, a major revolution that will require major investments, that will require bringing around the table many different types of competencies. The answer in my mind is both public and private. And I think that both sectors will have to be fully mobilized to face this huge transformation. Well, in the text that we see the intention of the authors. There is this open data portion in the French text of the new law. There seems to be a will to keep the public sector out of it. Yes, there is a logic where we would tend to say, yes, public bodies, we have available a certain number of data, and but there's also the idea of saying, let's make them more available, but there's also another reasoning concerning private data. I think there's an absolutely profound movement on transparency of clinical trials carried out by industry. They're under the pressure of the authorities, but also in a proactive way. The industrialists are now signing a certain number of agreements with the NIH in the US, for example. We see that the pharmaceutical industry is shifting towards this new movement to give more transparency concerning their clinical trials. Isn't it also a problem that lies with the notion of competition versus cooperation? Could you touch upon this aspect? Because ideally, all of the forces should be working jointly. How can each company survive unless they sign specific agreements, such as Novartis with Google? Well, I think there are a lot of legends with respect to the private sector, a lot of cliches, and a lack of knowledge sometimes. There's a sort of experimentation that I think is quite interesting at the University of Oxford. It's called WARN, the system. And they're experimenting with this system. It's a system to precocious alert concerning the resistance to anti-malarial medicine. And that's a huge international health problem. And what they did at Oxford University is that they collected all of the data from all of the clinical trials available concerning anti-malarial drugs. And everyone said, this is going to fail. The laboratories will never give you their data. And yet 80% of the data today have been collected in the system at Oxford. And today this system is more powerful than all of the studies and the Cochrane collaboration, which did meta-analyses based on not individual data, but data published. Based on the data, they actually reached results that actually were against the interests of the pharmaceutical companies who did release their data, and certain types of drugs saw their market authorization threatened by these results. So this transparency, the huge interest of what they did at Oxford was that they restored trust. It didn't they didn't come in a dogmatic way or to conquer, whereas in France, in our country, we are often very dogmatic with respect to the private sector and the public sector. I don't know what we mean by public sector when we talk about the SNIRAM, SNI-REM data from the National Health Insurance in France. Well, it's private practice, it's public practice, clinical, private clinics. All of this data is combined under the universal national healthcare system. So where is the border between public and private in France? It's not simple to distinguish. If we could restore trust by showing that we can truly, with all of this data, do things that will improve public health and everyone's health, individual health, then I think we'll really make progress. For example, in Saskatchewan, in Canada, it's a province, many years ago, they weren't even talking about big data, but there were analyses that combined, which is almost a capital sin because of the dogmatism we have in France. They actually combined mortality data, hospitalization data, and nominative data concerning care for asthma. And they were able to show that it was no longer necessary to use methods that it should be combined with corticosteroids to avoid severe crisis crises of asthma in certain clinical situations. It was published in the New England Journal of Medicine. It was a very determining factor. Thanks to this use of individual data on individuals, they actually made science move forward and individual health made progress. So I think if we can prove how these applications can be useful to patients, it would be useful. Now, there were 2 failures in the public hospitals in Paris. At a given moment, just like on the Beltway around Paris, I wanted to be able to forecast the traffic in the emergency wards. And we did this study called Esperanza, but it wasn't interesting to the authorities. And in the Geneva hospitals, they now have a smart HUG application, and it shows all of the waiting times in all of the hospitals. And if you have a broken arm, you can choose the hospital that has less people in the emergency waiting line. So it's a way people can personalize their own healthcare with this type of tool. The second failure that I experienced was there wasn't enough trust, I think, around this experiment. I managed the public health system in the Tournon Hospital in Paris, and I wanted them to display the number of nosocomial infections that occurred every day in every ward. And of course, it was impossible to implement this. And I think it will take time, but in my opinion, we will gain from this if there's more transparency to serve the patient, to better, so that people can steer their own personal health. They'd like to know which doctors comply with medical practices. For example, how can we end this resistance in France? This comes back to the fact that people in the end are quite well treated. If you look at an assessment scale of the French system compared with the Netherlands, the US, if people say if it places us below 10, it's because the scale wasn't good. What can we do to reduce this resistance? Well, I think we just need to create more transparency on the real results and the quality of the healthcare that we administer in this country, so that we can really pinpoint the inequalities and the disparities that exist that are major when we look at each disease in the way people are treated. But Antoine, what did you do when they refused? Did you go on strike? No. I wasn't convincing enough, I guess. Well, just one example. In Germany launched a movement a few years ago with the Commission on Quality to publish a certain number of indicators, quality indicators on hospitals. And they made this data available online. The first year, people were shocked. They said, oh, the data aren't reliable. Where did these data come from? And the answer was, they're your data. If they're not reliable, it's your fault. But nevertheless, we will use them. They're available. After 2 or 3 years, the reliability of the data was hugely improved. So creating transparency and doing certain things with these data in itself is a very powerful motor. I think I found the solution. I'm going to go see the Air France pilots. I'd just like to add one thing, just to give an example of something that's actually quite successful. The British Medical Journal published an editorial called French Lessons on Communicable Disease, and it's quite rare that the English take lessons from the French, but in this case, when you see the title, you can see that we can be proud. When they announced the Sentinel network of INSERM, they really opened up the data at a time when no one was talking about open data. It was 1984, and then in 95 it was published on the internet, and it was completely open, this network, the Sentinel network. And I remember the discussions with the public authorities that were very tense, but they were able to convince and restore confidence. Why was it so tense? Well, some people said for gastroenteritis, you'll see that the oyster growers are going to destroy your lab if you show that there's an epidemic of gastroenteritis in a certain area of oyster cultivation, or you might jeopardize the national economy and tourism. There's not just the healthcare sector. There are other sectors that may suffer from the data that sometimes might be poorly used by others. But they remained determined. They explained that there was a risk with transparency, but that we absolutely had to make these data completely open and available. And I have a slight disagreement with my colleague from McKinsey concerning open data for the health, national health insurance. In most countries in the world, there's a real, these data are closed for many reasons, but I can't think we can reasonably imagine that they can be open only to professionals, researchers, or institutes. No. Data, as Jean de Calvazoué said, Data is either total or it's not. You can't be half open in this sector, I think. I don't know what you mean by a researcher. A researcher is also a citizen. If the researcher has access, then everyone should have access. And I think that when everyone has access to this data, we could then probably reduce the problems of scandals, of vigilance that we're seeing today. And there is a risk here. Yes, there will be false alerts. But if we can do this with better confidence, better trust, and with good teams who work on this type of data, then I think we will all gain from this.
So, total opening up to citizens. How do we get to that point? Celia? Well, I think that from a data point of view, you've got to look at the granularity of the data. You know, are we talking about raw data or data that has already been processed? These are important notions. I'm going to cite a friend of mine who is a researcher and who works on open data in government generally. And very often he says that the data is empty because there is a lot of reprocessing of the data before it's put online. And very often associations find a lot more information when they look at websites, when they look for information available on websites rather than going via portals. So these are important questions. They need to be underlined. So if you're going to open up data, we talked about lots of transformations elsewhere in terms of redistribution of values, in terms of values enclosures, and enclosure of information, enclosure of data. I think it's important to see how we can really set up things from a legal and economic point of view. How can we set up these innovations in order to open up data, making sure that there is no recollection by big private groups for health marketing purposes. So I think it's important to have a clear vision and a global vision of the current ecosystem and the current stakes. These data governors, don't forget, they are the data of power. There are major social, economic and political stakes underlying these data. So we have to have a global vision and see how we can adapt things. There's a lot of work being done from an economic point of view. This is the case of the Commons, where legal institutions are setting up licenses that are more adapted to our world today, with all the transformations taking place in terms of technologies. So these things have to be taken into account, and we need to think about research from this point of view. So an optimistic note, a practical note, I think there's a basic movement that we will not escape, and that is the fluidifying of these data. The data are going to become more fluid. And then there's the attitude of young people in terms of protection of data and the quantity of sensitive information that's shared on social networks. There's almost been a change in paradigm in terms of attitudes. I think alongside this base movement with the explosion of data, and this is what Antoine said, we've got data that is in a bigger flow, if you like. It's more fluid. Up until now, the competition between private actors focused on access to data and being owners of data. And I think now it's not a question of access to data, but more a question of how are we going to process data using algorithms? How are we going to go faster than others? How are we going to be more insightful? So there are 2 points of view around this table. There's a progressist point of view. Little by little, we'll be converting. And then there's the fact that this system and certain things will be staying put until the last minute, and one day the wave will hit us and we will be deleted. So the medicine of the future, what we're seeing, this is something that Guy de Valenciennes described 25 years ago. Today's medicine was described by Guy 25 years ago, and we laughed at what he was saying 25 years ago. We don't need to talk necessarily about disasters. We've got 5 years to use data, to focus on intelligent big data, intelligent open data with the regulatory authorities who are not technophobic. We've got 5 years to develop the French industry, the European industry, based on algorithms and their intelligent and ethical use. The ethical use of data with a new framework, with understanding of the stakes underlying these data. We've got 5 years to reconvert the medical profession to make sure that doctors are not the nurses of 2030. Well, the nurses will be waiting to have a word with you during the break, says the lady. Yes, I'm quite happy with what I've just said. Okay, thank you to our speakers. I think that was a great debate.